And once again, thank you for the organizing committee to allowing me to be here today. So my talk will be related to the percutaneous pulmonary valve replacement. I have no disclosure related to this topic. Just to show you a little bit overview of how this kind of patient comes to us and need a valve replacement. So as you can see, for the TOF patient, some of them with pulmonary stenosis, they need surgical correction of the outflow tract. But some of them, which likely to be like pulmonary atresia, they need conduit. And other than the rest of that kind of lesions, like common arterial trunk or TGA or others, they need conduit as well. But unfortunately, this kind of patient is 80%, and that would be, pulmonary regurgitation afterwards. And about to be like 20% needs, with conduit, will come up with the pulmonary stenosis and pulmonary regurgitation. So this is how a few days ago, just to show you again that for those who had PVR, this is a publication published last year, long-term follow-up in post-TOF patient, about 1,000 repair patient. About 20% had PVR, and the mean age was about to be like 20 years. And 10 of the patient, about 1%, had second PVR. So the median age after the first valve replacement was 9 years. So it means, if you follow up patient long enough, at least about 36% of the patient need PVR after 40 years of age. So it's a big issue, of course, not in the UK, but also in my country. In my country, we have the mean age of TOF repair about 4 to 5 years. Of course, it's not because of the lack of the, how can I say, the procedure itself is not to that is 0 years after valve repair, and then maybe every 10 to 15 years you need to bring the patient back and do something on the valve again and again and again. Let's say if you have 70 years of age longevity, you will need maybe at least 4 to 5 valve replacement in life. And this kind of summarizing of the indication of why we need a valve replacement. In summary, just if you have RV dysfunction, if you have heart enlargement, especially on the right side, or significant TR, exercise intolerance, or even atrial ventricular arrhythmia, these need to be addressed. So option, of course, you can definitely standard surgery, a standard protocol be surgery, but nowadays cardiac intervention is emerging modality. So availability of the pulmonary valve nowadays, I think, of course, you all may know that Sapien and Medtronic Melody will be the big two. But it's not always applicable, especially for the native it's larger than, implanted if larger than 22. So limitation would be 5% of strength fracture without pre-stenting. You need to stent it just to prevent the complication of the stent fracture. And of course, you cannot use with a large native RVOT. And in Thailand, at least in my country, it's costly, so we cannot afford for all patients. And this is a Sapien, Edward Sapien pulmonary catheter heart valve. This is maybe the early generation of them. This made by the laser cut stainless steel frame and mounted with the bovine pericardium treated, specially treated by the company. And the maximum size of the diameter now, not now, but that time was something like 26. And this is in trial, of course. It's not available in the market yet, but this is Sapien 3. This is, information came since 2012, and the maximum diameter will be like 29 millimeter. It's a cobalt chromium frame at this moment, not a stainless steel anymore. And it takes just 14 French sheaths. So this kind of, very nice revolution of how we use, the valve to implant it. In the aortic valve or the pulmonary valve position, that this intend to use in aortic valve position, not in the pulmonary valve position at this moment. So inclusion criteria are quite the same, but they can use the Sapien a little bit larger like 24 millimeter. And limitation of course, even the stainless steel or cobalt chromium, we need presenting for landing zone, of course, and for large native RVOT, it's not be applicable. And of course, in Thailand, the cost is similar to Melody. Procedural risk, of course, this is very important. You need to be very careful. If you use this kind of procedure, you have to be sure that your coronary artery is not compressed when you stent it or you put the valve in. Just to give you some information, this is example of the case. Thanks for Shaq Qureshi giving me this. 25 years old, post RVOT patch and pulmonary atresia with intact ventricular septum, and now the patient had an exercise intolerance. So as you can see, some synovial part is here, and very significant pulmonary valve regurgitation. And so at the beginning, as a routine protocol, we need to do balloon interrogation to see how compressibility of this part to the coronary artery, especially left coronary artery, and then he stented with the LD max EV3, and then after that, after pre-stenting, you can wait for like 3 to 6 months and then come back again, or if you think it's quite significant PR and the patient cannot tolerate, you may move forward for like implanting the pulmonary valve. But the point that I would like to make is, now we know that even we put the valve very safely, but for some reason the patient Melody valve have had endocarditis, and sometimes it's happened like almost 2 years after first implantation. So exactly we don't really know what was the reason, but this is one thing that you have to keep in mind when you deal with this kind of valve. And just 4 years ago, maybe this is the first report of using the self-expandable valve for the position of the pulmonary position in the native RVOT, and it's done by the Bonhoeffer group, Mario Caminati, and also some of the big name is also here. And that was just a reported successful procedure, but since then we didn't have a good news from this group until now. So hopefully we can get that very soon. But if you deal with the large native outflow tract, at this moment I think on the market, of course this is available, but again this is not it's off-label use, using the Sapien XT, which is supposed to be used in the aortic valve to put into the pulmonary valve because it's the diameter is 29. But in this moment, as I told you earlier, that the venous PE valve is self-expandable one is probably one of the good things that maybe in the future we can use that, because the maximum diameter is nowadays coming to the 36 millimeter, which may be applicable for like 32, 33 millimeter size of the RVOT. Just to show you a little bit, the venous PE valve is self-expandable nitinol framework, and it's mounted. It's sealed by the porcine pericardium, and making the leaflet like this. So it takes like 22 French sheath delivery system. The problem for this one is you have to ask the engineer from the company to mount it when you have to use it, because you have to put this thing into the cold water and then crimp it into this delivery sheath, and then you can use that. Just to show you that this is kind of specification. The body here is about, you can customize it starting from like 15 to 30 millimeter, and here will be like 10 millimeter larger than the body, and also here. So this is supposed to put it into the bifurcation, and here is supposed to put it at the RVOT. Just to show you a sample, this patient, pulmonary valve diameter is about 30 millimeter and mid MPA 35 by 30. So our intention at that time was to put this valve in this position, like the picture that you saw. So as routine procedure, we do balloon interrogation, and we see how the waves appear like this. And then we use that as the landing diameter. I mean, like we need to oversize it about 2 to 3 millimeter at that position. And then we loading the valve, and mostly we have to start to load and to open it at the proximal part of the LPA, and then it's not coming. Anyway, and we opened it here, and then gradually, slowly, opening, and eventually, when it's completely expanded, it will look like that. So it's quite nice. I mean, if you deal with a very big RVOT, and it's just the beginning. So please wait for a second. There, and this is the echo showing that how this valve appears in the body immediate after implantation. This is a 3D picture of that. This is 32 by 30. 32 means the diameter of the valve is 32, and the 30 means the length of the body is 30. And the red color bar is the patient that I show you, and this is the MRI before, and this is MRI 6 months later. As you can see, it's very nicely decreasing of the RV volume, endoscopic volume index. I don't have time to go through all of this, but just to show you, this is very nice result. Unless one patient we had the significant TR because we pull too much back into the RV, so it's tangled the tricuspid valve. But in general, when you use this valve in the very large native RVOT, it get a good result, especially in the 6 months. And now I think we have 1 year follow-up, and all the patients are doing very well. An exclusion criteria for valve replacement, of course, percutaneously. If you have coronary compression, if you have too large RVOT, at this moment, I think if you have something larger than 32, you think you need to ask the surgeon to do that. And you have unstable catheter in RVOT position, or you have a body weight less than 30. But at least this is not the exclusion criteria, because you can ask your surgeon to go for hybrid if you want to, and that's also feasible. So in summary, ladies and gentlemen, I would say that percutaneous pulmonary valve replacement is an emerging option for the treatment, especially for the post-operative pulmonary valve dysfunction. And of course, previously it's almost impossible, but nowadays with the good technology, we can use this kind of valve to treat the dilated native post-operative RVOT. But again, the cost will be an issue, I think, everywhere in the world, especially for my region, Southeast Asia. And of course, this is maybe one of the things that you need to be very, very careful. We need long-term evaluation of this valve function and also complication. So thank you for your attention.